Coda Educate. So this is a first of our Coda Educate sessions. Natalie's going to just open with a bit of an acknowledgement of country, and then I'm going to run through the background of Coda Educate and thank some of our supporters.
The traditional owners of the land upon which we stand, and we pay our respects to elders past, present and emerging. And wherever you are in the world, we ask that you just take a moment to acknowledge the traditional custodians of the land upon which you stand. Welcome to Coda Zero.
So thanks, Nat. So we're really proud to collaborate with Philips, who are supporting this educational event. Philips aims to offer access to world-class healthcare education in order to enhance performance of healthcare professionals and improve patient outcomes. This premise is really, I guess, the core of the educate pillar for Coda. We've carried the medium is the message concept forward from SMAC, and we're really wanting to facilitate open access to high quality education and also tackle topics that are really pertinent to our community and driven by community feedback. So without further ado, welcome to Coda Zero Educate session. Really excited to have you on board and hoping to go away with some really good prototypes for change.
And so we're going to kick off with our first speaker, Martin, who is a junior doctor from Sydney, now working as a research scientist in health AI at Google Health in London. Martin, good morning, or good evening for you.
Thanks for having me.
Can you tell us what it is that excites you about artificial intelligence and the emerging implications for healthcare?
For sure. Thanks very much. So although I'm calling in from the UK, I am from Sydney, and I know a lot of folks are calling in from around Australia. So I'd like to acknowledge the traditional owners of those lands and pay my respects to elders past, present, and future. Now, in terms of the field of health AI and what excites me, I should say that I got into the field of health AI a little by accident. I'm from a medical background, and coming up through medical training, I really was a bit frustrated by the technological imbalances that we're all too familiar with now. The fact that despite all of the marvels of modern medicine, we still use fax machines. We struggle to get the records from the clinic down the road. We are rifling through too much information to try and find that critical piece of past medical history. And so I became really interested in information systems and data science, and that took me kind of after my junior doctor years to Stanford to study data science and machine learning, and then eventually to Google, where I now work in a research lab around how to sort of push the boundaries of health AI and think about the opportunities for AI in healthcare. And so it's a really exciting time for the field of health AI, because over the last 5 years, there's actually been this kind of confluence of a few different historical threads. We've had health data being increasingly digitized. We've had the kind of proliferation or accessibility of really large scale compute. And both of those things have unlocked this technique that was developed actually in the early 80s called deep learning, that is really good at pattern recognition over large data sets. And so that's actually where we've seen a lot of the exciting progress over the last few years in health AI, in spotting patterns, subtle patterns in high dimensional data. We've seen AI algorithms flagging diabetic retinopathy, better than specialist ophthalmologists, diagnosing malignant melanomas, interpreting pathology slides, calling variants in genomic data, and so many use cases, all with scenarios where the algorithms can shine by detecting subtle patterns in very large data sets. In particular, I wanted to highlight today a few kind of key trends that I've been particularly excited by over the last 12 months. The first is around sort of real evidence that's starting to be created in the field. Over 2019 and 2020, we have seen the first randomized clinical trials for an AI system in real world deployment. Actually, the colonoscopy field has been one of the pioneers in this space, and there have been trials in both the US and China of a automatic kind of polyp detection tool where a gastroenterologist sort of sees an overlay over the colonoscopy that tries to flag malignant lesions. And in randomized trials, that has shown to actually increase the number of early adenomas that are taken for biopsy in colonoscopies. Really amazing early data. Right? The second area I wanted to flag is sort of the potential for AI in scientific discovery, especially in its ability to use multimodal data. That is, not just one data type, but electronic health record data, imaging data, genomic data, and actually combining that to try and find patterns in this really high dimensional data that we're starting to collect about a patient. You think about so many diseases, sepsis, lupus, things like this, that medicine calls a single entity, but in truth, we know there's probably a cluster of lots of different disease types, and AI is helping us to try and compartmentalize or cluster phenotypes within those very broad diagnostic categories and find patterns again in this very large data sets that we're starting to collect. And so this is sort of on a stepping stone in the path towards precision medicine. And the final kind of thing that I'm excited by is really more of a very day-to-day operational use case of AI around trying to kind of expedite or improve the practice of medicine. So in the COVID era, we've seen some really interesting use cases of AI being used to, for example, forecast disease outbreaks or forecast resource utilization in different hospitals, the need for ventilators or ICU beds. That's helping to allocate resources in places like the NHS. We've also seen AI tools being used for sort of dictation, right, to reduce the clinical documentation burden, automate EHR entry, things like this. And so I think we need to really think outside the box about what the potential for AI is. There are some really blue sky speculative use cases around, defining new phenotypes for sepsis. There are some also really closer to home use cases that can affect the day-to-day practice of medicine for clinicians on the ground. And so I'm really excited about this field. It's not one without challenges, which I'm happy to talk about, but I think it's a really, really exciting space to be. And I hope, it's one that the medical community can embrace more and more.
Fabulous. Jesse, do you have a question?
So I'm putting it down to people who are a little slow getting used to the navigation of the question and answer tool at the bottom, but a couple of comments coming through. One of the things I just wanted to pick up, you said it's not without its challenges. I'll get you to elaborate on that a little bit if you don't mind, but also I guess that part of that is actually what I hear a lot is this fear that technology is going to replace us as healthcare professionals as well. So I guess there's a heap of challenges in there. We've got our eye very much on protecting ourselves a little bit sometimes when we're looking at technology adoption. What are those challenges that you see, and how can we kind of lean into those as healthcare professionals?
Yeah, there's a really good quote from Kurt Langlotz, who's a professor at Stanford working in radiology AI. It says that, AI won't replace doctors, but doctors who use AI will replace doctors who don't. And I think that really gets to the core of this, revolution that's happening in medicine. This AI by no means is going to replace clinicians. It's good at pattern recognition, but it is really not good at communicating with a patient, at human empathy, at understanding a patient's context, which is, so much of the value of a human clinician. Not claim to replace those things, but it can be a really, really powerful tool if we can use it correctly. And so I think there are a couple of really systemic challenges that the field is grappling with at the moment. If we can overcome that, then maybe we can get to that state where AI and clinicians can sort of work in harmony and, become better than the sum of their two parts. But some of those challenges include things like workflow integration. How does AI actually work in a clinical workflow? And then things like bias and equity. How do AI systems make sure that they are not perpetuating historical biases in health systems? So I can double click on each of those things because I think they're both worthy of discussion. On the workflow question, and there's actually been some really interesting thinking recently about how does AI dovetail with clinical workflows, because this is a problem across the field that people publish papers showing a really performant algorithm, a great ROC curve, but then these models just never get used. They go to the so-called model graveyard. They never make it to the bedside. So there's a lot of work now around kind of creative solutions to make AI user-friendly, human-friendly for the clinician or for the patient. So there was a really interesting paper published by Duke recently about their system called Sepsis Watch, that is a really interesting example of AI sort of being a safety net, kind of working in the background of a hospital, where it actually tries to detect patients coming into the emergency department with sepsis who have not received standard bundle care for sepsis, and then flagging the appropriate clinicians to alert them to this patient who might have slipped through the cracks. Right? Fairly simple, but this is something that's not trying to interrupt a workflow. It's just trying to sort of be a safety net so that patients receive standard of care. There's another example of actually a Google system where an AI system has been used with a microscope, such that for pathologists, so that kind of like a heat map is overlaid across the pathology slide, showing potential malignant areas or suspicious lesions in real time. So when you're looking down a microscope, you are attracted to the areas that maybe need more attention. And this is really interesting sort of examples of how AI can actually be integrated into the workflow. And then on to the second point around sort of bias. This is a really kind of hot topic around in the AI research field at the moment, because there's been a lot of recent papers showing that AI systems actually can be very discriminatory. There was a great paper out of Harvard last year published in Science that showed that an algorithm that was actually used in a number of US hospitals to predict risk was biased towards African American patients because it was trained on historical spending patterns. And a lot of Black patients had, because of their insurance status, had less healthcare spending. And so they actually underestimated their health risk as a result. And there have been a whole host of different examples in the imaging space with a variety of other data types. and accompanying that, an increasing field of literature that is thinking about how can we mitigate these biases, either by collecting better data, making sure that the data sets are really representative, but also thinking about statistical tools to make sure that the models are fair, and defining what fairness means, because fairness in a healthcare context is not always straightforward. So yeah, definitely not a field without its challenges, but there are some of the brightest minds in the world thinking about how to navigate some of these things.
Thanks, Martin. I wanted to ask you a question about the volume of data that you're talking about, because it sounds like everything is contingent on having the right amount of input to get the outputs that we want. Is there risks in involving siloed systems? Are there risks around corporate healthcare and ownership of that data? How could that affect healthcare?
Yeah, it's a great question. And this is one of the wicked problems of this field of health data science. You know, data is like the sort of the fuel for the whole field, but there is a delicate balance, because obviously this is sensitive health data, and how do you ensure that it's used, you know, properly? One thing that I've been really impressed by is the open data movement that's really been spearheaded by groups like the MIT critical data movement. So this is a group that tries to create large-scale de-identified health data sets for use by the research community. And they put out data sets like Mimic and other things, and started to do hackathons around the world where they will get clinicians and data scientists together in a room with a de-identified data set to kind of learn about the methods and kind of ideate about possible solutions. And I know, you know, in Australia, there have been a number of these datathons. ANZICS is quite involved in this movement. And I think this is a really powerful sort of philosophy that we should increasingly try and get behind: open data. The other thing that's probably worth mentioning is the idea of federated machine learning, which is becoming very popular in the kind of computer science world. And this is the concept of, you know, in some domains, healthcare included, it's really difficult to centralize data in one place because it's really sensitive data, understandably. So can we flip the paradigm and actually send, instead of sending the data to the central place, can we send a model, send an algorithm out to the data, and essentially kind of get and, you know, train the algorithm on the edge, you know, on a user's device, say, or, you know, on a hospital premises, and then remove the need to actually combine these different data sets. So, you know, there are methods like this that are starting to emerge that may help us to train algorithms without the need to, you know, to bring all of the data into one place.
Excellent, thank you. Jesse, I can see that there are now plenty of questions. Do you want to pick some that Martin can answer for us?
Yeah, it's firing up. I guess a quick one, hopefully, that you can chop off is there's a couple that I'll merge. Essentially about how, are there other universities that you're aware of, say Australian universities, that have opportunities like that, which you've had at Stanford? And I'll combine the question with one from Vic Brazel, which was, how do working clinicians actually get involved with this work with tech companies?
Yeah, so there are so many new opportunities coming online in Australia. I won't do them justice, but one opportunity that I'd like to particularly kind of highlight is the CHIA certification by the Australian Institute of Digital Health. This is the CHIA, Certified Health Informatician of Australia, and it's a qualification that is, you know, Australia-born, that is designed to help clinicians and and non-clinicians also upskill in health informatics and data science. It's a really good starter program to kind of get into the field. But there are so many other resources online, and I would really encourage. So I'm happy to be reached out to. Very happy to sort of talk to people who are interested in this space. But I truly believe, and I've seen this in the academic setting, and I'm seeing this now in the industry setting as well, that the bottleneck in the system is really not the technology. It's kind of being able to formulate the problem and having enough fluency in the clinical problem, as well as the capabilities of data science to sort of put two and two together and figure out where the opportunities are. And I would really encourage clinicians of all seniorities to learn at least the basics of data science, to be able to spot those problems and spot the opportunities and say, hey, this is somewhere where AI could be useful. And so there are a bunch of resources that can help with that. Google actually has a machine learning crash course, which is a free course online, the Google MLCC. There is a course on Udacity that has just been launched from colleagues at Stanford around AI in healthcare. And there's also a terrific blog out of Adelaide, actually. Luke Ogden-Rayner is a radiologist from Adelaide who runs probably the world's foremost health AI blog that is talking about the issues and challenges in this field. So those are a couple of resources, but happy to speak further about how to get more involved in this field.
Sounds great. I might just draw in Melissa to ask a question. She's just flagged interest in pitching a question to you, Martin.
Okay, thanks very much. Hey, Martin. I was just thinking about the challenges of this field and wondering if one of the potential issues as well is that it really reinforces a very biomedical approach to health. And, struck by the example of polyp, increasing detection of polyps, quite apart from the fact that earlier detection doesn't necessarily mean better outcomes for the patient or the community. I mean, the irony of earlier detection of polyps when so many of our communities don't have access to affordable, fresh, healthy food, for example. So just wondering, what do you think is the potential for AI to be used in helping to address the social determinants of health? And, also thinking of my colleague, Dr. Megan Williams, being here, Associate Professor Megan Williams, the cultural determinants of health. The social determinants of health and cultural determinants of health are so important, we've seen with the pandemic. So can the conversation be broadened beyond the clinic?
Yeah, it's a really, really great point, and thank you for raising it. I think this is one of the missing puzzle pieces in the field at the moment. Like so many things, it started in the places of medicine that have a lot of data, which is, the ICU and imaging applications, right? But really where AI can have a lot of power, where digital tools can have a lot of power, is in primary care and in sort of self-management of diseases. We don't necessarily need to slightly expedite the workflow of the subspecialist radiologist, doing polyp detection. But what we do need to do is manage diabetes better and ensure that people with heart failure who can't see a cardiologist can get some sort of advice. Right? And I think there are some good examples of that starting to emerge. One that comes to mind is the use case of diabetic retinopathy in Thailand. So there's been a project to try and use an AI system to screen for diabetic eye disease in low resource communities, including in Thailand and in India, and try and detect early signs of blindness in patients who would otherwise not have access to an ophthalmologist, right? And I think this is an example of a system which can be deployed at scale, deployed cheaply for a population who would otherwise potentially not have care, that can dovetail in with traditional medical systems, because it's not necessarily replacing an ophthalmologist, it's just triaging which patients get sent to the ophthalmologist with highest priority. I think examples like that are really powerful. You're starting to see this as well for things like, again, in the diabetes space, home sugar monitoring for diabetes, say, like AI-driven tools that will help patients to self-monitor their chronic disease at home and make decisions at home. So that's kind of one space. But as for the social determinants of health, I think one area that like a clear problem at the moment is that a lot of social determinants of health are not even made visible to the clinicians who are treating the patients. It's like really difficult to find the relevant information about social determinants of health. And so, creating data platforms that allow that information to be better captured and surfaced to the clinician, maybe identifying patients who have particular social risks and need to be targeted early, for example. This is a really great opportunity for digital platforms. So yeah, I think that the TLDR here is that this is probably an area that hasn't received enough attention by the AI community, but is definitely on the radar. And there are more and more papers coming out and groups specifically focusing on how to address some of these wicked problems in healthcare, the social determinants that are sort of so embedded in health systems and patient experiences, and that the hardest problems to solve, both with AI and with a medication. It's difficult, but we're getting there. It's like definitely being thought about.
Thank you, Martin. So you've kicked us off with a really broad range of exciting hopes for the future in terms of AI and machine learning, but caveated with some concerns that this is a real time of generation of new ideas, and we've got an opportunity to do this the right way.